everyone to this webinar put on by the Institute of Health Economics with our friends from the Bright Shores Research Institute. Just wanted up front to provide a land acknowledgement, which you can see here. We realize we are located in the province of Alberta, but some of the people joining us live on ancestral lands in other parts of the country and the other parts of the province. And we make this acknowledgement as an act of reconciliation and gratitude to those whose territory we reside on or are visiting, whose histories, languages, and cultures continue to influence and enrich our community. And we'd like to acknowledge the harms and mistakes of the past and the enduring effects of systemic racism. And we dedicate ourselves to creating safe and inclusive spaces. Hopefully, this one will be that strengthen collaboration, build respectful relationships, and engender change. So just as thank you very much for joining us. This is the first in what we hope to be an ongoing rural health policy series, and we're very pleased to have our colleagues and friends from the Bright Shores Research Institute to be the inaugural participants in sharing some of their learnings and practices. And we have two people who will be presenting today, Neil McLean, who is the Executive Director for Bright Shores Research Institute, and he's the inaugural Executive Director of that organization. And he brings over 2 decades of leadership experience in health system transformation and innovation. And I know from speaking to him a strong commitment to equitable and sustainable solutions in rural communities. And joining him is Rebecca Brookman, who's the Director of Research and Innovation for the Bright Shores Research Institute. And she leads the research strategy and innovation development there. And I think it's a unique organization because of its nature. It's affiliated with a formal health system in Northern Ontario, but dedicated to research practices and how it might inform and drive change in rural communities. And so we really welcome them sharing their learnings that we can perhaps adopt in other places across the country. They're going to be providing a formal presentation. I'll be operating the slides, and please do put questions and into the Q&A function, and we will address those after the particular presentation. So without further ado, thank you everyone for joining us. I'm going to pass over and be the slide operator for Neil and Rebecca as they present some really interesting work that this dedicated research organization is doing. It's new, and I think it's involving in what is an exciting journey that we can all learn from. And so I will share the presentation, which hopefully, Neil, if you give me thumbs up, if it can be seen. And so I will pass over to Rebecca and Neil to provide a presentation on the great work underway from Bright Shores Research Institute.
John, on behalf of Rebecca, thank you for the opportunity to join the Institute for Health Economics in Alberta from Ontario and to be part of Rural Health Week, which is, I think, phenomenal, just given our unique focus from a research and innovation perspective. We look forward to discussing why is rural healthcare different? And I'm excited because I spent a lot of time talking to urban people, convincing that rural is different. And so maybe this could be people that are doppelgangers to Rebecca and me, that share similar areas of focus, but also similar passion around addressing the gaps and the equity divide that exists between urban and rural communities, specifically to healthcare. Next slide, please. So I'll skip over the speakers. John gave us a great intro. So our sort of brief agenda for our overview, we want to just give you a bit of a sense of who the Grey Bruce region is of Ontario, but also why it's somewhat ubiquitous in terms of its the challenges, its demographics, the rurality compared to other communities across Ontario, but also across the country. What are the implications for the work that we're leading and trying to transform specific to policy and system design? The component of the Research Institute itself, which John sort of alluded to being new, we were incorporated as a not-for-profit with charitable tax status in July of last year with an independent board of directors. What does that uniquely enable us to do compared to traditional research and research institutes? And our fourth component really is around opportunities to explore and open the door to policy conversations, and the fact that the challenges we're tackling are beyond what any one institute can take on. And it's going to take more of the hands than just ours to bring these pieces to life. And we've deliberately left about 30 minutes for some questions and discussion. So our next slide is sort of an overview of where are we in Ontario. So on the left, you can see Ontario in green. The sort of here's the scope of it, and we are in the sort of southernmost tip on the west side of Ontario, uniquely bounded by Lake Huron and Georgian Bay. And I would say the wonders of the Niagara Escarpment. So those individuals that like hiking, maybe not quite the Rockies, but from an Ontario perspective, it's a beautiful part of the country. But I would say the uniqueness of what is Gray and Bruce and the organizations that represent the Bright Shores Health System, which are the 5 dots centered around Owen Sound, is really the sort of our sort of main sort of founding partner that had the vision to launch the Institute to do a couple of things. One, to focus on bringing quality of care to the rural hospitals. But the other dimension to this is, how does an organization focused on providing acute care to rural communities meaningfully integrate care into the community, and how do you build purposeful partnerships, and what do integrated models of care look like? On the right are some of the vignettes of the local towns, from small towns to the beautiful harbors, and I would say the region of Grey Bruce is home to about 175,000 people during the winter, and uniquely explodes to over 2 million short stay visits from vacationers and cottagers to people that are retiring to community, which I think really sort of exacerbates the challenge or challenges around meeting the needs of people that are wanting to live in rural communities with this massive inflow and exflow of people coming in and out of the region in terms of the ability to plan and coordinate services, but also how do we recruit and retain healthcare workers across such a dynamic region? Thank you, John. The next slide. So the slide probably isn't going to be unique to Albertans, but from an Ontario perspective, the unique focuses for people living in our rural communities. We know that people living in our communities are losing access to primary care physicians at a rate of 12% a year, which is 4 times faster than people living in urban communities in Ontario. There's an estimated about 500,000 people, or 525 people, living in rural Ontario today without a primary care physician, which means they're seeking other points of care, predominantly emergency departments across the province as their single point of care or only point of care in many instances. The region of Grey Bruce is at a 27% greater risk of people dying from cardiovascular disease than anywhere else in Ontario or anywhere else across Canada. So from a research and innovation lens, why is that the demographic? And also from a transformation perspective, what can we do to leverage data to predict the needs of people that are likely going to become susceptible to cardiovascular disease? And how do we bring the might of communities to better to support and intervene upstream and or prevent these diseases escalating to ultimate death? Rural communities are constantly on the front pages of Ontario's newspapers and in the media for the number of times their local emergency departments have been closed. More than 600 emergency department closures over the past 2 years in rural communities just in Ontario, due directly to the inability for hospitals to be able to recruit and retain primary care physicians or nursing to support and deliver care in these uniquely rural communities. And then the last stat here, which is near and dear to me personally, is just the shortage and the impact of the lack of access to mental health care. And survey through the Rural Municipal Association of Ontario identified more than 60% of communities across Ontario reporting a lack of access to mental health and addiction services, which in rural communities is exacerbated with just this heinous addiction to opioid and fentanyl. And how do we support people that are some of the most frail and vulnerable, but also addicted to some of the most challenging and most addictive drugs? These are unique to rural communities, and part of the focus of the Institute is, how do we bring about transformation? How do we work with frontline staff, but also organizations to form coalitions if they're willing to tackle these wicked system problems? Next slide, please, John. To transform rural healthcare, I've alluded to Bright Shores Health System, our founding partner. It was their board that had the vision to launch an independent research institute, so at a high level, the health system, 6 hospital sites, a strong culture around innovation, as you'll get a sense from the work that we're doing on the research side. But they also have a strong voice and commitment to investing into community partners through innovative models around mental health and community mental health programs and services. And they're also looking to define what does healthcare look like through an academic hospital lens in 2030. 5 years away, not 2050 or 2070. The next, could you press the button one more time, John? The Bright Shores Research Institute, as I've spoken to, was launched in July of 2024, independent, not-for-profit, with charitable tax status, with the unique focus on rural health and rural innovation. Our research is specifically aligned and informed by the challenges that we've heard from frontline nurses and physicians and community providers to meet the needs of people in rural communities. And it's their voices and their wicked problems that together we're trying to tackle. And together we're building an ecosystem of like minds to build a sort of multi-sector collaboration. Next slide, please, John. So we want to have poke a little bit of fun at the words Bright Shores Research Institute. And so Bright Shores, but if you press the button one more time, John, while we share the name with our founding partner, the Institute itself is fully independent and focused on shifting healthcare upstream from hospitals and into community. And the focus on becoming independent, and also our goal is to become financially independent from the hospital by March 31, 2026, will enable us to build relationships with organizations that are hard for hospitals, specifically industry and with government and with academic partners. John, if you press the button one more time, to poke fun at the word research. When we talk about research, people think about Bunsen burners and test tubes. And while there is the need to bring evidence and best practices to inform our focus, our focus is uniquely around innovation and transformation. How do we meaningfully disrupt the way healthcare is being provided and planned and coordinated today to address the real world challenges facing people in rural communities? And John, one more time, the word institute, it sounds like sort of brick and mortar. It sounds rigid, and I would say our team is anything but. When we went through branding and engaged stakeholders to get their perspective around, like, how would they describe the work we're doing? The word that kept coming back is the word feisty, determined to disrupt status quo. We're nimble and agile, and also wanting to work across multiple partners and building purposeful partnerships that may or may not represent a traditional sort of institute. But I would say the pace of change that we've undertaken is atypical from an academic lens and happy to be challenged by academics on the call. Next slide, please, John. So when we think about the focus on rural and our focus on Grey Bruce, it is our contention that the research and innovation initiatives that we're undertaking are really tackling Canada's rural health and wellness challenges by uniquely focusing on the needs of people living in Grey Bruce as a microcosm for the broader rural health system issues facing people in rural communities across the challenge, which also sort of speaks to our vision, which is the next slide, John. which speaks to where do we hope to be in terms of defining that we're doing and where are we hoping to go and how will we know when we get there. Our vision is to be the foremost research institute, uniquely building connections to elevate health and wellness outcomes and drive meaningful change for all rural communities, which sort of speaks to our vision, which is the next slide, which is how do we know when we've gotten there? Our mission is really around building a culture of inquiry and partners, including the Bright Shores Health System, our founding partner, with healthcare researchers and providers in the community. The focus of our institute is to tenaciously conduct, enable, and advocate relevant scientific investigation that has the potential to transform the rural healthcare paradigm. And then I think I have one more slide, John, in terms of our value proposition. And so our value proposition, I love this slide with the man carrying the child, sort of the next generation of the rural perspective. Our value proposition is for healthcare researchers, providers, and patients, the Institute drives essential and transformative research on healthcare issues unique to our rural communities. And so I think at this point, I'm going to pass the virtual baton to my colleague, Rebecca, for the next slide.
Thank you, Neil. It's nice to be here with everybody today. As you've been hearing a little bit of background about who we are and where we're coming from, we wanted to share with you what our areas of focus are for the next 3 years. And not surprising, based on the demographic of seniors that we have within our region and that expected to grow, we really want to focus on enhancing the opportunity for these people to age in place. It's where they want to be. We need to keep them out of the hospitals and home and as healthy as they can be, and providing supports not only for the patients that are cared for in home and community, but for the families and the care providers as well. Secondly, there is a really important need to improve access to healthcare. Access can be limited for a number of reasons, and we see that often is exacerbated in rural regions, and some of those being remote. In terms of, it could be connectivity, it could be the infrastructure or the travel in the winters that sometimes we receive in gray roofs. Many reasons there for us to have a lot of challenges to focus on and come up with solutions to improve access to healthcare and make it really equitable for the residents that are within rural regions. And thirdly, we need to focus on our champions, and those are our healthcare workers. How can we support them? And that looks like a number of different things. But we think about developing integrated models of care where healthcare workers can work amongst interdisciplinary teams in seamless ways, finding tools for them that are innovative or digital technologies to help them monitor patients easily, to reduce the admin burdens. We hear that so often, especially from our physician groups as well. So anything that we can do in this area to really support our healthcare workers in terms of their ability to work and be well physically and mentally as well. Next slide, please. As you've been hearing about our goal to really change and drive transformation, we fully believe that it's the partnerships that are going to drive rural healthcare transformation. As we look at these massive challenges that address so many of us and probably all of the sectors that you see depicted here, these are big problems and problems that we can't solve independently, working in silos. So coming together and working in partnership to lead transformation that's going to last and that's going to be able to scale is very important. So we aim to bring together some of the brightest hearts and minds to drive innovation and research for Grey Bruce and beyond that, rural communities across Ontario and beyond. When you look at sort of the flower image there and think of some of the partnerships that could be depicted, it's like-minded organizations that are coming from industry, academia, not-for-profit, government, all of these different partners coming together to really collaborate. And a big piece of this promotion is also prioritizing Canadian and getting Canadian businesses to be supported and coming together to come up with local solutions. and really engaging the communities as well in what we're doing. The patients and the family's perspective is extremely important as well. So we'll move on to the next slide. And we'd like to share with you, there's a lot of exciting work that's happening at Bright Shores Research Institute. So we'll just pull out a couple of examples today and give you a little taste for some of the work that's ongoing. And this slide speaks to the opportunity to expand virtual health and community-based models. And in particular, the image that you're seeing here, this is Amber Harrington, who is the Bright Shores Health System nurse wound specialist. And we were really fortunate at Bright Shores Health System to receive funding over a year ago from the Digital Global Innovation Cluster. And it brought together the partners that you see here in this consortium to do really important work. And using the Swift skin and wound technology, it's essentially an application that you can download to your device, and it allows frontline healthcare staff to take a picture of a wound and gives very accurate measurements of that wound. It details various characteristics of it. So historically at Bright Shores, you've been hearing and you saw on the map, we've got 6 sites that are spread out across a region of 8,600 square kilometers. And this individual had to travel around to all 6 sites to try to prioritize where she needed to be each day to see the wounds that were coming in at all of the sites. Having this technology has allowed us to implement it at all 6 of our hospital sites, putting it in the hands of frontline staff to take really detailed images and feel confident that an accurate and detailed wound assessment has been done. And then there's the opportunity to prioritize and escalate those as necessary. So it's been a fantastic project. We're about halfway through, but there's so many opportunities like this to expand the use of virtual and hybrid care models to really sustain rural hospitals. And I see that research and innovation can have a vital role in trialing these out and refining the opportunities that we have. Next slide, please. The other example we wanted to share with you is related to reducing the hospital dependence with providing access to remote patient monitoring tools. The one that is depicted here, this was a fantastic project. We're just wrapping up, and we were really fortunate to have funding through the Can Health Network. Bright Shores Health System was one of the first rural edges in Ontario to become a part of this network last fall. And through this funding, Bright Shores was able to partner with Grand River Hospital and Patient Companion to trial this in our healthcare setting. So essentially the funding allows opportunity for new techs, Canadian made, to have a space in healthcare, trial them out, and give a lot of feedback back and forth, which allows these companies to receive patient and user feedback and make real-time changes that are needed and are necessary and are what really the patients and the users want to see. So in this instance, you're probably familiar with the typical historical call bell system. You're laying in bed as a patient, you need a drink of water, and you press the button, and a beep goes to the nurse's station. You wait a few minutes, and somebody comes to find out what you need, and then they go back to get you a drink of water and bring that back to you. So this technology is a fantastic idea. And what they have is an application that allows the patient to specify what it is that they're requesting. So beforehand, the unit can think about how they would like to present this to patients. If they'd like to, if it's in a women in childcare unit, for example, perhaps breastfeeding is something that comes up often, so they would put that as a button. But there's the ability to customize and to free text your request to the nursing staff. So again, this is supporting our healthcare patients. It's our healthcare providers. It's saving them steps. If they know right away there's a drink of water that room 201 needs, then that can save some steps, or perhaps a student or volunteer can go and do that. And our registered staff can prioritize their tasks to more acute roles. The experience for our patients has also been a benefit for them to be able to articulate what it is that they need and specify that as well. So this is just one example of, again, how tools such as this can help with remote patient monitoring, and we want to see that those are integrated back into the community and home care. And again, improving patient experiences as well as providing tools to make the lives of our healthcare workers better as well. Next slide, please. We've also had the opportunity to bring clinical trials to Bright Shores, and this is phenomenal. You'll think about experimental drugs or clinical trials that happen are often in large urban city centers. So for folks that struggle with perhaps a rare disease that's in a rural region, for them to access some of these experimental treatments mean that they would have to travel hours, sometimes multiple times a week, to receive access to these things. And quite simply, it isn't feasible and often isn't a reality that's possible for many of these individuals. So they have to decline opportunity to be involved in those. So the opportunity to bring clinical trials home to rural regions is fantastic. And the picture that you see here, the two ladies on our right, Kaylin Clark and Rebecca Johnson, are our two research managers, superstars of our team, and they're partnered here in the photo with Robin Nasilla and Dustin Brown, who are our two nurse practitioners who are leading this clinical trial, and particularly related to mental health and addiction. You heard Neil speak earlier about the importance of that. So a number of clinical trials are happening, and again, just another opportunity for research and innovation to improve access to care for patients in the rural home communities that they live within. Next slide, please. So you've heard a little bit about who we are and our passion and our ability and desire to disrupt. And we are looking for like-minded individuals, and we hope that there's some of you on the call with us today that will join us. Think about ways that we can work together, whether in your corporation, if it's pilot projects that we could test new models of care, joint research initiatives on rural health workforce planning, whatever that might look like. It could be funding and policy collaborations to really shape that next generation of rural health services. We're interested, so please reach out. There's lots of opportunity. And I think, John, if you press the button one more time, we want to just really hit home today that these local solutions can become global ones. So this is just the starting point of something much bigger, and we'd love to work together with you because we truly believe that the future of rural healthcare starts right now. So thank you so much. Really appreciate the time to be here with you today, and we'll turn it over to John for questions.
Thank you very much for the presentation, and really thanks everyone for joining us today. And again, people, if they could put any questions in the Q&A, that would be really helpful. And I have a couple, but certainly I'll address the Q&As. One Scott had Fielding, and Scott, it's good to have you join us. The about rural healthcare, are we including remote? And is there a way that you guys classify in your particular region those people who you would classify as rural and as remote? And is that a kind of a structure in your thinking of how you look at your demographics in your region?
I can start. We've deliberately focused on rural, and it's interesting because when we think about even just defining rural, the definition of rural is vague. I mean, so you could spend a lifetime trying to define rural, and so even around like where does rural start and stop? I would say the potential to translate knowledge from rural to remote is possible. I think as we get into the remote, patient populations become more disparate and further afield. Access to connectivity becomes harder. You know, the just access to almost everything becomes harder from a rural to remote. I think the deliberate focus on rural is how the opportunity for us to translate models of care from urban to remote, but also how do we close the gap from an access to care perspective, even from an equity lens that exists today, for the ability for people in urban settings to walk down the street and get care from a walk-in clinic or urgent care clinic when they don't exist today in rural. I think the question about remote is potentially that's a step 2 for us. But I think like from a partnership perspective, open to learning. I would say the communities that we're also supporting within Grey Bruce include 2 Indigenous communities as well. And so we think about the diversity of patients that are people that are living in the region. And, what does aging in place mean? Even from a rural lens, from an inclusion perspective, we're also thinking, well, what does that mean from an Indigenous lens as well? So I don't know if I've answered the question. Or if it's a hard one to start with in terms of remote versus rural.
Right.
Also, I'd also welcome feedback.
Just one quick question. There was another question, but just a question I had. I know you're trying to move to sustainability, you said. And just a question, where do you receive the bulk of your funding now? Is it affiliated with research projects that you've been able to kind of gather and group around? And what is your path forward in terms of expected sources to become sustainable and perhaps a mix of public and kind of private sources, but just if you could outline current funding, and then what are you seeking frankly in order to hit your target in 2026?
Yeah, so we've been very fortunate to have a purposeful, and I would say founding partnership relationship with the board and with the CEO of Bright Shores Health System and Ford, who had the vision to stand up the Institute. And so they've given us some operational dollars as seed funding. They've also been extremely generous with the provision of in-kind services for all the back office support. And we lovingly refer to ourselves as, the teens that live in the basement. We've grown up and gone away to school, and we've kind of come back, and every once in a while we raid the fridge. Well, at some point the parent's going to put the lock on the fridge and maybe change the lock on the front door. And so part of our vision is, by March 31 of 2026, is that we become financially independent and financially self-sustaining. So our goal for this year, which is bold, is to raise $3 million in operating dollars that would sustain our core team, but also give us dollars to invest in meaningful projects to transform and disrupt rural care. I would say my role as executive director is also that of business development lead. So forging partnerships, but also defining the value proposition of why invest in rural to industry partners that are actually really interested in terms of the ability to identify rural as in some ways an untapped market from a medical device and a technology perspective for philanthropy. And hospitals have done this well for years in terms of the ability to raise capital. How do we engage, or the opportunity to engage individuals or organizations focused on sort of social purposes, like enabling the better coordination of care for the communities that people or organizations of high net worth are living in, or where their staff are working in. And I think, what intrigues me with the work that the Institute for Health Economics has done and is doing, John, is, how do we develop the value-based models of care to demonstrate to government, whether it's regional or provincial level, that meaningful investments in terms of rural health up front have a multiplication sort of factor in terms of downstream savings by the ability to invest in terms of some of these small projects that we've spoken to. Today, I would say the vast majority of the funding we've received, which is almost about $1.5 million so far, are coming predominantly from the federal government through either the Digital Supercluster or Can Health. But the pathway for us is really around diversifying revenue streams in a thoughtful and creative way, but also in a way that's leveraging purposeful partnerships. We want to work with people of like mind and shared purpose.
Great. No, thanks very much. Rebecca, I don't know if you had any comment in response to that question, or can go on to others.
I was just going to add one other thing to the initial comment that Neil had shared about the rural and remote. It's funny, when we first started out, there was discussion amongst our rural hospital sites about who was more rural than the next, and was Owen Sound really rural compared to Lion's Head. So there is a subjectivity to it, but it's interesting, some of the connections are not as straightforward as you may assume. And we've been asked to be a part of the External Advisory Committee for the Institute of Earth and Space Exploration at Western University. And when I went home and told my family this, they said, "What on earth? Like, we thought you were working in healthcare. What does this have to do with space exploration?" But there's a lot of context there that's similar when you think of remote in the sense of monitoring the health of an astronaut in space. That's truly remote. But is there opportunity to partner in the sense of trialing some of these technologies in a more rural and remote region on Earth before sending these to space? I think there's some really neat opportunities there that we're going to explore.
That's great. And I do know, and you mentioned, Neil, that we had some great early discussions just a bit ago about potential things of the IG kind of potential collaboration and bringing certain skill sets in partnership with you, and what you bring as a portal into access to patients and data and platforms where you can engage with local communities. And I think there's great opportunities perhaps for collaboration across the country for comparative type structures to be able to improve their small numbers and have a more robust numbers of where you can do comparative research in different provinces. But just flipping through to a couple of quick questions. Rachel had asked, how do you collaborate with Brightshores Health Research to implement Brightshores Health System to implement and spread and scale innovations that you have? Is clearly there's a financial commitment, but in regard to the particular innovations and projects, how is that relationship with the Brightshore Health System leaders commitment to scale and spread work that you do?
So maybe I can start, and Rebecca, you can jump in. So we started deliberately with a research advisory council that consists of department leads and nursing executives, and even the hospital CEO sits on, that meets on a sort of monthly basis to identify, so what's the next sort of wicked problems facing the health system we want to tackle together, as well as updates around, well, here's where we are across the work. I would say that's how we started. I think as where we are today, the interest across other rural communities outside of Grey and Bruce has also sort of forced us to think about how do we bring an advisory council together that enables voices and perspectives, not just from a hospital lens, but from primary care and home care and long-term care, but also for health systems that are outside of even Grey Bruce. So we're literally thinking through, how do we maintain this sort of research advisory council within Brightshores, because they are a core hub today. But how does that become augmented structurally that enables us to bring ideas, needs, opportunities to partner with those organizations that are outside of this founding organization, which is, when you invited us to join the webinar today, I was excited by this because I think you have like thousands of organizations that are following on LinkedIn, as well as your members. We're not bound by geography. And if anything, what we've seen is, it's going to take the power of many and the brains of many to help us solve these. And many of the projects that Rebecca's sort of given you sort of a taste, they're digitally enabled. So they could be connecting patients for wound care across the street or across the region. There's nothing stopping us from doing things even across boundaries. So as much as we have I would say, a symbiotic relationship with Brightshore's health system, it really is the metaphor of that awkward teen living in the basement, and really we're getting our own feet under us, and we're building those relationships based on this base that the hospital system's given us to explore opportunities that could actually test the models within Brightshores and then scale them out, or potentially even bring models from outside the region and bring them in. Right. To Brightshore, so it's bi-directional.
Yeah. Rebecca, I don't know if you had any comment to
add. Just your last sentence there, Neil, is what I was going to chime in and say too, is just we're starting to see that now at our state of maturity as we're starting to get through projects and finish things off, and lots of lessons learned and being able to demonstrate success. We've done this here in multi-sites. And now let's bring it out to regional partners and we can help them facilitate it within our rural community and others. So exciting opportunity there. The other thing I'll mention is initially, as we started out, again, this is just a natural state of growth, is we became the funnel very quickly of opportunities coming forward. So how do people reach out with the invitation to do a project together or wanting to co-apply for funding? And very quickly we became inundated really with great opportunities to bring forward, to take to some of the stakeholders in hospital and out in the community. Hey, here's a potential solution. Is this an opportunity for you? Will this fix a problem that you have? But as we continue to grow, we're starting to see now, we want to see more of this. I think it's exciting that people are starting to come forward and say, hey, I've got a problem. And they're from the bottom up are coming to us with problems and looking for us to help bring those identified solutions that we could trial together.
Yeah, great. I'll do two questions together. One was, and I think it was Ellen who might have asked, do you have access to health administrative data through Bright Shores Health System? And are there key gaps that you have? Because often the secret in rural areas in particular is integration, because you really have to kind of, it's hard to have a bunch of separate silos. And so do you have access to administrative data, and how is that structured, and are there kind of gaps? And the second one, Anna had noted, do you have examples of innovations implemented to address fluctuations in population throughout the year? Is there a kind of where you've big kind of shifts in changes in demand for healthcare system? Anna, I think, obviously has an example that she might be thinking of in her own work. But those two quick questions kind of together. One is the access to data, where you might have some unique things you've been able to work out or have some gaps, and the other one is fluctuations in population needs throughout the year that might be addressed.
Sure, I think I can start with both of those. So in terms of access to data, yes, it's very project specific, and obviously there's protocols to follow and ethics and approvals to get access to Bright Shores data, for example, through the EMR and so on. The challenges that were suggested there in terms of getting data from community partners with disparate EMR systems, we are experiencing those, and those are real. And there are lots of instances, for example, the wound care solution that I shared with you, where the baseline data to, when you're doing your evaluation, it's nice to have baseline data to compare to. Sometimes it doesn't exist, and sometimes the problem is so deep, or the tools are not sufficient that you haven't been able to collect some of the metrics. So your change is from having nothing to having a lot of something. The second question that was asked in terms of, have you had the ability to identify if there's a major flux and change? And I'll say we're undergoing a project right now. It's actually another CanHealth project with a company called Emerge Connect, and it uses a technology to allow patients in the Emerge waiting room to self-triage to the extent of filling in the information that is asked from a nurse when you go and sit with them. It doesn't replace that from happening. They still go and have that conversation, but it has the information already in the computer by the time you get up to the staff. So it's saving some admin time for them. We expect to see an enormous change in flux there, because as Neil shared, we have 175,000 residents across all of Grey Bruce, but that will explode to 2 million short stay visits in the next number of months over the summer season. So having some of these solutions, and we're purposefully testing them in quieter seasons and then in our busier seasons to see, does this technology keep up with us in the massive changes that we see? Neil, maybe
just to compliment John. So I don't know if Ellen's in Ontario or not, but I would say the Ontario lens is probably a lot more fragmented in terms of, we have 58 Ontario health teams that are sort of been charged by the province to define integrated models of care, from congestive heart failure to COPD to palliative care. They each have access to their microcosm of administrative data. So we're part of an Ontario Health team. We also have access to Ontario Health data through the Ontario Health teams. We have access to data from the hospital systems that we're connected to. But I would say it falls down when we're trying to figure out like which patients have home care. And if our core focus is enabling people to age in place, how do we glean the needs of what people are struggling with in the home without access to home care data or even the mix of home and primary care data? So we're on this journey quite literally to overcome these silos of data, but also the silos of funding that are keeping people from collaborating together. So it's this mosaic that we're
Yeah.
trying to build to share.
Yeah. Too quick. That one, Ellen works with IHE and is
Okay.
one of the many data gurus that we kind of have, and I think
Oh,
Alberta's
so it's
in
a
a
loaded
better
question.
situation. But I do think actually it's interesting. One was you mentioned the Ontario Health Team, and does the Ontario Health Team align responsible for the geographic or the grouping of services in your area align with the Bright Shores health system, and whether, because do you have a kind of a primary care organizational hub that aligns a bit with the acute care collection?
So the Ontario Health Teams are independent organizations. They're not incorporated. They're partnership models. And
Right.
so organizations volunteer to say, I would like to be part of this, and I'd like to share and support and be part of whatever comes out of it. I'd say the Bright Shores health system, just because of its size, provides a lot of the back office support, but it also has, I think, some of the sort of, the clinicians and some of the thought leadership as well that's guiding, informing the OHT. And it's not a criticism of the OHT, but they're all, I would say, from my perspective, the OHTs are significantly underfunded and under-resourced to tackle these wicked problems. And so they're looking for organizations like the Institute and for us to help bring these initiatives to life, but also to help bring like minds together, to bring these initiatives together. So we really are we are a catalyst for change in many ways.
Yeah, I do think it's important, particularly in rural settings. Sometimes there's an expectation that collaborations will happen by serendipity or whatever. Sometimes there needs to be purposeful infrastructure to develop. Betsy has a question, but before I'll get to that, one was I wanted to know: do you have a kind of a main academic kind of partner that you're aligned with, either the Northern University or University of Toronto or that kind? I'm just wondering, it's because often that kind of hub of ongoing academic work that you affiliate your projects with, do you have kind of a base alignment with, and who might that organization or organizations be?
Yeah, I'm smiling because our answer is no, but our answer is yes. And so we don't, like, this Bright Shores health system is not an academic health system. It's a collection of small, medium hospitals of significant geography and size. And so in the absence of being an academic health science center, we can partner with any of the universities that we want to work with and collaborate with. And so whether it's through medical schools or nursing schools or through research, and like Rebecca can attest to this, is with, I think, the change in even like the tri-agency funding requirements for CHR and NSERC, applicants require a meaningful relationship to rural, Indigenous, and remote partners. So we've had requests to partner from BC all the way across to McGill on significant clinical trials, but also academic research initiatives that we wouldn't have had probably that access to if we were tied to one academic institute. And so this is going to sound terrible, but I would say we can choose who we want to work with based on what the opportunities are, but also based on what the areas of focus of some of the various medical schools or universities or nursing programs are.
Right. Okay. No. Thanks for that. Betsy's question, regarding the examples that you shared, have you conducted or in the midst of conducting evaluations, including health economic analysis of the programs and interventions that you're demonstration projects that you're working on?
It's a great question, and I'm hoping that I can connect with her. It sounds like she might have something up her sleeve. Yeah, we're certainly underway from a number of evaluations, but that's an area where I see a big opportunity for us to grow. And Neil had mentioned earlier about value-based care and some of the metrics about patient experience and preventative measures that are really hard to put a number to and really hard to get data about.
Yeah, yeah, because I think it is important as you kind of deal with the scale and spread from something that's an interesting idea to be able to kind of match up how it's going to kind of disrupt and uh,
I would say
change.
I would say we have a quite ambitious 3-year strategic plan, John, and we haven't really spoken to our board. We have a seven-person board. Two of the board members cross-appointed from the hospital. The rest of the board, as independent board members, represent the country of Canada. So our board chair is based in Vancouver. They represent nursing, industry, hospital partners and experiences. But as we're going through our strategic plan, their question to me as the executive director is, how will you know that you've moved the needle towards the achievement of the strategy, which is to enhance the ability for people to age in place in rural communities, to improve access to care, and to improve health human resources to be able to work together. Like, those are really hard to, like, how do you assess the sort of overarching impact of these overarching sort of areas of focus? And I think we know we can do it incrementally through the projects that are aligned with these strategies. But if there are people on this call that have advice towards, like, how do we bring the macro lens towards the sort of macro or aggregate view towards the achievement of these strategies, I'd love to speak with them.
Yeah.
And when I meet with leaders from across other provinces, even other countries, this is my first question of them is, how are they doing this? And I usually get a blank look back, and not because it's a look of indifference. It's just a really wicked hard problem to solve.
Yeah. Yeah, and certainly, and we've had some discussions, Neil, I think Canada is, and some other countries are unique. I talked to some colleagues in Europe colleagues in the Netherlands where I say, you don't actually have rural healthcare because you can drive across your country in about 40 minutes. And so we do have some unique experience in terms of our geography and our small population. But just a couple of quick things, and then because we're going to have to wrap up, but I want to leave Neil and Rebecca. The title was why is rural healthcare different? And I think if you had to kind of explain to a decision maker or to someone the answer to that question, the key lessons that you think where people misunderstand or don't know the key point about rural healthcare delivery. So I'll let you think about that for a sec before I answer. But I wanted to share with everybody, we are conducting an event, which I just wanted to share with people in right now, and hopefully people can see it. We're doing a rural health policy forum. And I put the link to the registration in the chat, and it's on June 9th. And this is with support of the province of Alberta. We're doing it up in Grand Prairie, and there's in-person capacity, but also we're going to be having a remote connection. And I think we have a great faculty, some colleagues from BC and from Alberta to be able to discuss in a afternoon format, a number of rural health service planning issues and unique needs, and a special attention to health workforce needs. So just wanted to know, I'll send the little link and also the PowerPoints and follow up to this call to everybody. But just for a final word, Neil and Rebecca, your wise sage wisdom, frankly, if you had to say why is rural healthcare different, specifically the opportunities or the challenge, that would be great to hear from you of any kind of final words associated with the title of the webinar.
It's a great question, and thanks for the 30-second warning. I would say from a policy lens perspective, I've sort of spoken to a couple of things. One, the funding silos that exist in Ontario between primary care and home care, and even acute care hospitals, have created, I would say, significant barriers for people that want to work together to improve care for people in rural communities. from working together. It's impossible for people to share data. There are financial incentives almost for people not to want to work together, but it's because of who people are. I've respectfully referred to frontline nurses and physicians in rural communities as truly the MacGyvers of healthcare. They're solving some of the most wicked problems with the tools at their disposal because they're providing care for their neighbors and for their families. It's fundamentally different than the policies that are being set based on the line of sight from an Ontario perspective out of Toronto, where the Ministry of Health is, and looking down University Ave with some of Canada's biggest hospital systems. We don't have the ability to walk down the street and get urgent care. I share with you the demographics of the populations living in our rural regions, which I think are true for the most part for rural communities at large, but that's compounded with the fact that we're losing access to primary care physicians at twice the rate of people living in the urban centers. And so it's really why our focus is on rural, and it's really why we're looking for like minds to help us tackle this. There are all kinds of opportunities to collaborate and bring models of care that have been developed and pioneered in urban into rural, but also to enable collaboration and communication with technology.
Yeah, and thanks. Just a comment. I know we've done some work in Alberta, colleagues of mine in IG, really trying to look back to geography, and you can get trapped into provincial averages. You know, the average rate of this in Alberta is this, and it sometimes can become meaningless in that there's wide variation in distribution if you look at the postal codes in which people live in terms of their services. But final word to you, Rebecca, before I close.
I don't have much more to add other than, yes, these rural folks, they wear many hats, and what they can do is amazing. They have an innovative spirit, but more than that, these are people that deserve equitable care, and the access to care in rural regions simply isn't equitable. So I want to see a change there. I'm passionate. I'm biased because I was born and raised in a rural region on a farm, and I love the community. I don't want to be anywhere else, but I want to know that my family and the generations to come after me are going to have the care that they deserve and need in rural communities where they live.
Okay, thank you very much for that. And if anyone has any ideas of particular kind of topics, this is part one of a rural healthcare policy series that we hope to have. And so we will certainly communicate to people in joining. But thanks, everyone. And join me virtually and kind of thanking Neil and Rebecca for sharing the great work that's underway, and hope you become sustainable in 2026 and look forward to ongoing connection and work. But thanks everyone for joining us, and everyone have a good rest of your Thursday day, and thank you for joining us.
Thank you.
Thanks, John.